Hey everyone, welcome back to another episode of Clinically Correlate with Azfar and Vedant. Today we have Dr. Kevin Hiatt, a neuroradiologist at Wake Forest and one of the co-founders of CaseStacks, which is a radiology educational platform that he created when he was a trainee at Wake Forest. Kevin, really excited to have you on. Thanks for joining us today.
Thanks so much for having me. I'm really honored that you thought of me and invited me on your podcast.
Yeah, absolutely. So, personally, I love CaseStacks. I kind of recommend it to everyone. That's why I was really excited to when we met each other at the at AUR conference we went to recently, and glad to have you on. So
Awesome. Well, thanks for using it.
yeah, absolutely. So we'll get into that. So kind of starting from the beginning, can you just tell us, what was the inspiration behind starting CaseStacks?
Yeah, great question. So as you mentioned, I did my residency training at Wake Forest and started in 2015. And so at that time, the co-founder of our company and I were co-residents. Scott Jones and I were co-residents at Wake Forest, and we were first-year residents preparing for call. And Wake Forest has an independent overnight call, and so it can be a pretty daunting thing, preparing for call, really concerned that you don't want to miss anything or hurt patients. And this kind of daunting prospect of taking call was very motivating for me and for many of my co-residents, and it motivated us to learn and to practice as much as possible. And so we used a variety of resources. We used textbooks, we used online resources, things like Radiopedia, StatDX, RadPrimer. We had a very strong call curriculum from our attendings who walked us through cases, tried to make sure that we were going to be able to make the findings we needed to on call. And we took our daytime rotations seriously, but we realized that the only real guarantee on daytime rotations was that you wouldn't see everything you needed to. Like, some people might see one case, but you wouldn't see that case, and there were going to be things that you were going to see on call that you weren't really prepared for by your daytime rotations. And so realizing that, we knew that we needed more practice. And so we used filters in our packs to review all the studies that came through our emergency department over the past day. And so I would spend hours just kind of going through cases that had come through overnight and seeing, what the residents had seen. And that was certainly good. You'd see real world cases, but the efficiency wasn't particularly good. There was just a lot of normals. There were some pathologies you would just see over and over again. You'd see like tons and tons of kidney stones. You're like, okay, I've seen enough kidney stones. But then there were other pathologies that you really just didn't see. And so that system made Scott and I realize, we need something else. We need something to supplement our learning. And so we that's what motivated us. We wanted a more efficient hands-on tool as a supplement to the residency training process.
How did you get started from, just being able to search it on PACS to ultimately building CaseStacks? Because that's, most residents don't have the skill set to, one, develop a website, to even kind of integrate it with PACS, make something that's very functional.
Yeah, and I honestly don't have that skill set either. This is where it would be nice to have Scott online, just because he's really the brains behind this. And so Scott had some background in web design and had done some of that in college, and so he knew some basics about how to create a website and that kind of thing. And he kind of came across an open source DICOM viewer and was kind of playing around with it. Can we upload cases? How can I do that in a web design? And he really caught the vision earlier than I did, and then brought me on, a little bit after. But he, kind of realized this is something we can do. We can use his knowledge about web design and use some existing platforms out there to start showing cases and start collecting them and presenting them in a way that is interactive for residents. And so what we started out with was actually a fairly dysfunctional product, a fairly not very efficient thing. And hopefully he's not listening to this, but It was pretty clunky up at first, but we kind of had a vision. And, we said if we can show cases in on a web-based platform, then really the sky's the limit. We are people, we're learning, we have this knowledge to, know what residents need to be able to see. And so we started working on that. And so what we decided to do up front was this was about a year after we started training. So in 2016, we're now second years, just like you guys. We were second year residents, and we had tinkered some with the design, and we decided, we really need to have some kind of a test product. And fortunately, we had a lot of guinea pigs, which were our fellow residents, to try it out. And so what we decided to do first was let's just tackle one specific topic. And so we decided to cover some of the can't miss diagnoses on neuro CT. So I was primarily involved with putting the cases together, kind of finding them, putting them together, and doing write-ups for the cases. And Scott kind of found a way to make it work where residents could go through those cases and take them. And so we tested it out on our residents back in 2016. We were second year residents at the time that we were testing it out on our first year residents. And honestly, I'm impressed that they tolerated us. The tool was kind of clunky and load times were not particularly fast. But they stuck with it, and they gave us some really good feedback, which was overwhelmingly positive, that they felt like it was a very useful tool, and gave us some areas where we could improve the tool. And we, over the following years to come, we spent a lot of time trying to make the tool better, and then also trying to expand it to include things outside of neuro CT. And I'll have to say, along the way, we succeeded largely due to the encouragement of our faculty, who stepped in and really helped us out. In particular, Carol Gear, who's our program director, was very supportive of us along the way. And so also during that time, we began meeting periodically with our institution's innovation center, which culminated in us, negotiating a contract with them prior to actually going public with our tool in 2020. So we've been live for about 4 years now. So.
Got it. No, that's an amazing story. And like you said, one, being able to do that while you're second year residents and you're taking like the bulk of your call, it's very impressive. And two, I think, the toughest thing about medical education is every time you figure out a problem and a possible solution to solve it, you don't really have the time to actually solve it. And I think that's what kind of prevents most people from medical education kind of improving across the board, unless you have honestly very passionate educators that either are doing it in real time, like in your case, or taking time kind of 10 years into their career, kind of retrospectively look back. But the toughest part there is always at that point, education's changed so much. Do they know exactly what like the residents need? So, definitely like these homegrown tools that are created while you're a resident, and even now as like a junior faculty, you have a much closer tie to what we actually need at this time, which I think is it speaks to why it's such a successful product.
Well, thank you. Yeah, you're absolutely right. And when we think about radiology and our ability to bring our educational tools to the current century, it's really only us who can do it. No one else has the knowledge that we do about our specialty. And so if we want our educational tools to be better, it's on us to take ownership of that. And so we were very lucky to be in a position where we had support from people, but I'd be lying to say that we didn't sink a lot of our nights and weekends and vacation time into this over the years. So yeah.
I bet. And I mean, we're kind of thankful that you put in that time. Makes it much easier for us to go through those cases. So, just a few follow-up questions. So you had mentioned, you got the cases. So just to clarify, did you get those cases from like a Creative Commons Radiopedia angle, or were they all, kind of homegrown from the Wake Forest system?
Yeah, they were all homegrown. So all of our cases are from our institution, and so we developed the system for anonymizing these cases. So, most PACS software programs will have some kind of an anonymizing tool. Also, just to put a plug for this, the RSNA actually has a really nice DICOM anonymizing tool that works really well. It's very easy to use, which runs off of a Java platform. But so we then, we've gone through multiple iterations of this, but we painstakingly checked our data, combed through the DICOM headers to make sure there wasn't any information. And actually, before we could go public with this, we had to get sign off from our hospital's chief privacy officer, which was super fun. And no, actually, went a lot smoother than I thought it would. But so yeah, so we're very careful to make sure of that. But how did we get the cases? Um, I'm somewhat of a hoarder. So as I go through, as I went through rotations as a resident, I was one of those people who just saving like tons and tons of cases. And so I built up a fair amount of cases that way. But on top of that, we had to query the system to find specific examples of things that we need. And I have no financial association with this, but our department has a tool called Montage. There are some others that exist out there that you can use to kind of search packs and look for specific diagnoses. And so I've spent, I don't know how many hours just, going through these tools, trying to amass cases, trying to find the perfect example of whatever, or the perfectly gray or the perfectly ambiguous example of something. And so, but to loop back around to your question, yeah, that they're all from our institution.
Got it. No, it's funny that you said that. So the one of the co-founders for Montage is an attending at Penn and is one of
Oh,
our
nice.
podcast guests who was also talking about like entrepreneurship in radiology. So we use it all the time for a lot of different
Mhm.
purposes. It sounds like it was the backbone for you guys getting started as well.
I I love it. You can pass this along. I have no ties to this at all, but I would definitely. I'm a big proponent of it. It works very well. I've used it almost primarily to find cases when I need things.
That's awesome.
So one of the things that you mentioned while you're getting your product off the ground was engaging with the innovation office. What was that experience like overall? And if you could summarize kind of very briefly some of the steps that you had to take that you didn't anticipate, and then any kind of advice for residents who are also thinking about engaging the innovation office to build products that involve, I guess, university or hospital system property.
Great question. There's a lot to unpack there. And I will give you the caveat that I've interacted with my institution's innovation office and innovation center. I really have no experience with any other institution's innovation center or innovation office. And so I don't really have a great grasp on how standardized this is across institutions. One thing I will say that I know is fairly standard is if your employment contract that you sign, many of us without really reading it, is will have some kind of language in there about intellectual property. And the things that you make as a resident or as an attending are based off of many of these contracts are the property of the institution, right? And so you created these things, but you were being trained by them at that time, and they have some claim to your intellectual property. And for many people, that sounds prohibitive to developing a company, right? Like, I'm going to put all this work into developing this thing, and then the institution just owns it. And for many people, that sounds not good, and might even prevent them from wanting to pursue things. And so many institutions have some kind of an innovation office or an innovation center to help both encourage innovators and to also help make what they're doing sustainable. And so our innovation center, we started meeting with them fairly early in the process, as I said, and it was somewhat like a Shark Tank experience almost, where you go and you pitch your idea and you get to hear their feed. There's this panel of people and they kind of give you their feedback on it. And our product, unlike a lot of others, didn't require a lot of capital to get it off the ground, right? Like buying an IP is nothing, and server costs are not that much when you don't have a lot of much of a user base. And so we weren't particularly looking for capital, but we were looking for we knew at some point there would need to be some kind of a relationship with the institution. And so but we did get some good advice from them, and there's a lot that I can talk about starting a company, and a lot of things that we didn't have expertise in, and they certainly gave us some good advice. And so we met with them kind of off and on for several years, and then eventually negotiated a contract with them that was both profitable to us, that was would allow us to operate as a business and not be held back too much, but also was something attractive to them. One thing I will say, just as what I learned from that interaction, one, it's always good to get other experts involved whenever you're doing anything. There's no way you can possibly know everything. You can't know how to start a business, how to do advertising, how to manage your own accounting, how to do, there's a lot of things. You can't do everything. And so for anyone out there who's interested in starting a business as a doctor, like, you can't do everything. And so it's good to be able to to find other people to help you with advice. Another thing I would say is at least my interactions, and this may not hold true for everyone, but my interactions were quite positive with them. They didn't seem like they were trying to steal my intellectual property, or they seemed very supportive and interested in us succeeding. One thing I will say, though, is that the institution will always put its interests first, and that's just how it is. It's not that they're bad, but they're just always going to look out for their own interests, and so you need to look out for yours. And you always need to advocate for yourself. And so one thing I'm really glad that I did along this process is putting the investment into having my own lawyer, having my own legal help through this process. They were helpful in negotiating contracts and just making sure that we were protecting ourselves up front. Not that the institution wants to hurt you or wants to, behave immorally, but you need to always make sure you look out for your interests. And so, but overall, I felt like it was I'm overall happy with where we are, and did get some good advice from my interactions with them. Now those interactions may be very different depending on what you're doing. So I know people who've worked on patents and have been looking for industry sponsors to help develop products, and that's a very different situation than mine was. And so that interaction with innovation was very different.
That's very helpful, actually. I think there are many points that we can generalize to all residents, regardless of what institution we're coming from. And now, kind of to summarize everything, kind of looking back, what was the toughest part of starting your company?
Yeah, I think it's kind of twofold. Sorry to not give you one toughest part. It's kind of two toughest parts. It's hard for me to pick which one, so I'm just going to give you both. But the two toughest parts were the time and the expertise. So time, as you might expect. So you don't have like a ton of time as a resident, as you guys are well aware. And you don't want to compromise your residency training to do something else, right? Like you went into residency, this is what you should get good at. And so because of that meant a lot of after hours work on this. And so for years, both Scott and I, and we continue to do this, honestly, have poured our nights and weekends and vacation time into developing this. And some of it's really fun and exciting, but there are also parts to building something that are fairly mundane and not as exciting. And so you just have to set goals and set tangible goals and just try to accomplish those goals. But one good thing about this in particular, from the time investment standpoint, is that there was actually quite a bit of overlap with between what I was creating and what I was supposed to be learning anyway. in residency, right? And so you know, make a chest CT module and you're like, oh yeah, that's stuff I need to know anyway. And so, you know, you'll never be in a better position to build educational material as you are when you are currently learning it. And so so that was certainly that made it a little bit better. But the expertise side of things was tricky and continues to be tricky. And like I said, you're not going to be a master of everything. And so we, through the process, we naturally developed some expertise in radiology just by nature of going through our residency training program. And so by the end, I would like to hope that we are at least to some degree content experts for, you know, for the radiology topics. But the other parts of, you know, expertise required to start a company are not really part of most residency trainings programs. And so, as I said before, our innovation center was helpful, offered some advice and resources, but honestly, for the most part, we kind of figured it out on our own. And we sourced some family members and some friends who did have some expertise, at least in some of these areas, including in advertising. Um, but we and on top of that, we hired lawyers and accountants to help us kind of figure out how to do things. And so that meant for us as residents living on resident salaries, a fairly substantial financial investment from our standpoint, just to kind of get some of that running. And so this process included, you know, figuring out how to form an LLC, how to protect our intellectual property, how to construct and execute an advertising campaign, how to adhere to national and even more scary international tax laws, which is still kind of something that we're working on figuring out. How to obtain business insurance, you know, what degree of coverage do you need for business insurance? And then also the ever-pressing issue of cybersecurity, both for us as a company, you know, you don't want your product to be compromised by that, but also protecting the information from your users, their contact information, whatever information they have. And so that's been tricky, and it's taken, you know, a lot of time to kind of figure it out. Fortunately, there are a lot of resources out there on the web for, you know, for how to accomplish these things. But it was certainly very challenging to figure all those things out, and we're still honestly trying to figure out some of them.
I love how granular you got on all the different aspects of, you know, whether within radiology or within like the business expertise that you need to know. Because I think that's what folks that, you know, if you're not in business, you know that that stuff exists. But again, like we just don't get any training for that. And so to be able to even identify like what skills should I possibly learn or will need to learn, it's kind of nice to just have it broken down, at least on a broad level, of at least what you went through.
Yeah, and honestly, if anyone would like to talk, like if there's anyone out there who wants to talk through that process, I would be happy to. It's some of it ends up almost being kind of a trial and error, and you realize, oh man, we need to figure out how to do this, and then you know then you work on that. But there's a lot to it. But it's also kind of interesting too. You know, just like things that I kind of wish I had learned some of those things before, you know, before coming to medical school, but unfortunately did not. So,
No, 100%. So I guess, you know, we've been talking about how CaseStacks got built. Now let's pivot to where CaseStacks is right now. So, you know, for those who haven't tried out CaseStacks, could you give us a broad overview of exactly what you all are offering?
absolutely. So CaseStacks is a web-based platform. So you just go to the URL, and so you don't have to download software or anything. It runs entirely off the web. And we have you can create a free account and see some of the cases for free just to see kind of what it looks like. And some of our resources also on the site are available for free. But what we offer is a subscription-based service, as everything is these days, right? Basically, every single thing that you interact with is a subscription-based service. But we offer it for individuals, but also for institutions. And so there's institutions that have plans for their residents, but we also have individual users all around the world who use this. And our major and most used offering is our call preparation course, and that's kind of what I've talked about developing is this what now is a pretty fleshed out course, including over 1,500 fully interactive cases that are modality specific. So you go through lessons that you go through neuro CT or neuro MRI or pediatric radiographs or musculoskeletal radiographs or abdominal ultrasound. You go through these lessons, and it's set up in a case-based style, but it's kind of an intentional collection of cases that we think residents should be familiar with before taking call. And one thing that we're very proud of about our design that's really unique among most tools out there is that we include classic cases. We include what you might expect to see if you open the textbook, but we also include what we call practice cases, which are real-world cases. They are either more complex, more ambiguous, more subtle, even some normals mixed in, or normal variants that are common mimics of pathology. And so, we feel that this is a very high yield way for residents to gain a base, exposure that they need to have before taking call, but also get some good practice that will be very translatable to what they'll see on call. And so many programs around the world use this to supplement their residency curriculum. And we think that it's a nice pairing with existing curriculums that exist. It also serves as a valuable resource for residents on call. The cases themselves are a resource, but we also have things like a PEDS normal database. What does the elbow radiograph look like in a 5-month-old kind of thing, which I can never keep straight. Some things like what to do about incidental findings on imaging studies, and also some anatomy modules. And so that's kind of our major offering right now, and what most programs use. We are developing some fellow level curricula. And so Scott Jones and I are both neuroradiologists. And so that's often where we try out things first, just because that's where we feel like we have our expertise. And so we're building some neuro fellow curriculum level modules as well. And also are working on some medical student anatomy, or I'm sorry, some medical school modules as well, just because I do quite a bit of teaching in our medical school. And so always interested in building that direction as well. So hopefully that gives you somewhat of an overview. Certainly would encourage you to check out the site, and yeah.
Absolutely. So I think, the call prep is how our institution is using it. Both as when we were R1s, that's what we were prepping. And then, I think honestly, you learn what you need to know on call, because you realize, oh, this is like, you just need to get a chance to get exposed to what call is like. And it's nice to, have CaseStacks available to continue to refresh your memory of certain processes, or just do a deeper dive on things. And then, including right now as an R2, I'm part of like the ED readiness course. So as part of that, we're kind of telling the R1s what cases to go through, and it's predominantly CaseStacks based. So, I think that's pretty much in line with like most other institutions. Something that, you and I talked about at AUR was, where do you see in the spectrum of like radiology education, ideally, not just where program directors, maybe can justify from a cost standpoint, but if you were kind of dictating radiology education by yourself, where do you think would be the best time to really have CaseStacks be available?
Yeah, that's a great question. With specific regard to the call preparation curriculum, which is the bulk of what we have out there right now, I think that certainly the people who are going to benefit the most from it are the residents who are preparing for call. And at many institutions, that will be the first and second year residents who are kind of gearing up for that experience. That being said, at our institution, we kind of keep an eye on who uses it. I'm always just curious to see who's using it. And we actually have quite a few fourth-year residents who use it as well. And they use it as a call resource. Also, a lot of our fourth years are doing essentially mini fellowships, or they do a lot of time on nuclear medicine, and they're like, I haven't been on neuro in a long time, or I haven't been on peds in a long time. And so they use it as a refresher. We also have a fair amount of fellows who use it. And so when you think about it, a lot of people are, especially people who take private practice jobs, will be reading things that are not specifically what they studied in fellowship, right? So they might have an emphasis in musculoskeletal imaging, but that doesn't mean they won't be reading some other things. And so we see a lot of fellows who use it as like a ramp up to their job, just to go back and, maybe they've mastered musculoskeletal imaging, but they want a refresher on chest imaging or body imaging. And so I think it's certainly good for that. That being said, we also have a substantial user base of practicing radiologists. I know this isn't actually what you're asking, but we also have a user base of practicing radiologists who are either switching jobs, or they're starting to take new responsibilities at their existing job, and they're like, oh man, it's been 20 years since I've read this. And so they use it to kind of help prepare them. So that being said, I think anyone who is looking for a tool to help them prepare for radiology call, I think it's a great resource for that.
Got it. No, I mean, that's great to hear. I didn't realize that attendings would be using it too, but it makes sense.
Mhm.
Because everyone, definitely needs a refresher. And then, part of the reason I was at AUR was, for the procedural task force for general radiologists. And like the, modules we created was for the same kind of cohort, both, like trainees, residents, and fellows. And then if you were switching jobs or you just needed a refresher, here's kind of a nice, easy way to see things in a 15-minute module to get your refresher that you need. And it sounds like a lot of radiology jobs are just so different location to location. So you never know what you'll actually need to know or refresh later on in your career.
Mm.
So the other part that, I know we spoke about was, I guess, because I don't have experience of what it's like to be an R3 fellow or an attending, but what I do know is as a medical student, as an intern, as an R1, those are kind of like 3 years effectively as well. That maybe you're not necessarily like preparing for call, but honestly, in my opinion, like even starting from like when you're an MS4 and you're like, I want to do radiology, once you say that, it takes about 3 years until you're an R1. So like, anything to be able to do anything. And I can say like, even being an intern, like people would ask me radiology questions and I honestly wouldn't know anything more than my co-interns, but like they would just assume you did. And I think that's a pretty common experience among a lot of radiology residents. And so the
Mhm.
problem is like radiology training itself, it's not like a core curriculum as part of medical school. It's a lot of virtual, or at least when we were there a couple years ago. But even now, it's like watching someone in the reading room is not a very like interactive task, and it's tough. Like you don't usually have your own packs and your own power scribe to like be able to simulate to like understand cases, and to even contribute to the team. So you're really just a glorified shadower. But like the way I see CaseStacks is, once you say that, I want to do radiology, like whether the program can pay for it or even out of pocket, like it's similar to like a UWorld subscription. And so it'd be great between the cases being available, the findings being outlined through CaseStacks, and then now like there's so many search patterns that are available on YouTube. 10-15 minute video, you can understand how to go through it, and then you combine that with Radiopedia, you have a lot of the toolkits in like a MacGyver way to at least be able to be like, all right, I know how to approach a CT abdomen, I know how to approach a CT head, and like at least rule out the big stuff.
Mhm.
Because I swear, like I didn't know I was a general surgery resident. I could take care of like patients with appendicitis on the floor, but I wouldn't know how to diagnose it on CT, which like in
Mhm.
retrospect, it's like it's not complicated, but like finding the appendix takes a while, even as an R1. But like
Oh yeah.
if you have a bunch of positive cases, but you don't even know how to apply like a normal search pattern, it would be nice to be like, oh, I've seen a lot of positive cases, and that's a positive one. And at least have a simple like binary yes no filter that you can apply. And then like when we start as R1s, um, you're kind of hitting the ground running, because like radiology just gets more advanced in our imaging. And to keep kind of being like spend 4 weeks doing x-rays, 4 weeks doing just ED, CT, abdomen, and pelvises, like at some point we got to speed up that process. But you know, I don't know
Yeah.
if you both agree on that.
I'm absolutely in agreement with that. And I think, it's kind of interesting. We try to get our fourth years. So I actually run an acting intern. I'm the clerkship director for an acting internship in diagnostic radiology at our institution. And I do have students dictate cases as part of that. They get their pack station and they get to dictate. But and I also use our fourth year students going into radiology. We make them kind of glorified residents essentially and let them help us teach in the medical school and get that experience. But you're absolutely right. And with regard to CaseStacks specifically, we wrote the curriculum from the resident perspective because that's kind of how we were going through things. And now as we've interacted with this more and we have people from other specialties using it, I've realized that we need something even more basic just to kind of help bridge that knowledge gap that exists. And so we're actually working on, this isn't like completely public knowledge yet, but we're working on releasing a course that's going to be more intro level that will hopefully flow nicely into what we have as the call prep curriculum. But yeah, I'm with you. I think that any chance that you can get as a fourth year student, as an intern, to start practicing and getting better at it, the better off you'll be hitting residency training.
Yeah, that's amazing. So you guys are expanding, I guess, to like other specialties outside of radiology. Um,
Yeah, so at our institution, CaseStacks is integrated into the emergency medicine, internal medicine, family medicine, neurology, and neurosurgery curriculum. And so obviously the neurosurgery residents aren't doing every part of the website, but they're doing what's relevant to them.
yeah,
And yeah, they use it extensively, as much as our residents do. Some of them are like super users. They go through quite a bit. But there's a lot of specialties. There's emergency medicine doctors who are responsible for reading their own plain films overnight,
yeah,
and they're scared about that, and they should be scared about that. And so this gives them a chance to practice as well.
yeah. I mean, like even as like speaking as like a general surgery intern, you oftentimes the ED will call you before the read is done, right?
Oh
Because
yeah,
they see something and then now you're looking at it and like you still have to make some interpretation of what's going on. And I
right.
think like most of like the non-radiology specialties, they learn imaging primarily one through like their training, but that's like very much an ad hoc basis, like even more so than our training is. Or it could be like static images based off of their board exams and the prep associated with it.
Mhm.
But like again, that doesn't simulate like the real world of like, is it easier to see appendix on coronal versus like axial, right? And just like getting a better idea of where it's going to be. And like it's like those minor things, or even like I think with like PEs, it's all about windowing. Once you like know how to window properly, it's like follow the vessels. But like, it's not any of like the standard windows that like will normally be there on a
Right.
keypad. And that's something that like regardless of your specialty, including from medicine to even probably neurosurge, because half the time it's like, and they start anticoagulation in like one of their post-op patients if they think there's a PE, like there's always going to be a timeline between when they see the scan and then ultimately when it's read. So having that like basic skill set is there for a lot of other medical skills, and we're finally getting there with radiology because the imaging's there, the education's there. So that's great. It's great to hear.
Mhm.
I think an important benefit of kind of expanding to other specialties is you realize the limitations and advantages of certain imaging modalities, right? And I think, so many times we get phone calls during call about, what study they should order. If we are lucky, sometimes they just often order the wrong studies. And I'm not dinging them for not knowing,
Mhm.
no, going through fourth year and intern year, I realized how limited our education was on radiology. If anything, they just taught chest X-rays and maybe that was it, right? And and so, I hope people realize, hey, ordering a KUB for following constipation, not the best idea. Or non-con chest CT for PEs, not the best idea, right? But again, it's we don't get that education, right? I think
Mhm.
that I like to believe that partly contributes to over imaging that we have. It's just we end up ordering everything under the sun because we don't know what the most appropriate imaging is. Even though we have ACA appropriateness criteria, but that is just a gigantic block of text, and it's somewhat convoluted to get through, right? But I think as soon as we have some base level of understanding of the limitations and advantages of certain imaging modalities, when we combine that with clinical data, I think it becomes a very powerful educational tool. And I think, on the same level, I think other specialties are, or at least now, are trying to expand their education into more and more into imaging, which I think should help with like the crazy amount of volume that we're seeing. Um, but I
Certainly.
think, diverting off of that, our last part, which is my favorite part, the hot takes. I
Okay.
think, as an academic radiologist in practice, oral boards are coming back. Fortunately, I think fortunately, it's just after, it will be applied just after the year
Uh-huh.
after us. So
Right.
like, and so what are your thoughts on that? Do you think it's a positive change, a negative change, or are we pretty much neutral on this?
Yeah, it's the current first years, isn't it? That will
That's
be doing
right. That's
that
right.
will be doing the oral boards. Yeah, I think I don't know. I've kind of gone back and forth on this one. I think whether positive or negative, it will certainly give people a lot to talk about, and that's always a good thing. People like drama, but it will certainly be different. And I think so. Yeah, this is an interesting topic. So one potential positive, just to lead with that before I get into what I consider the negatives. But one potential positive is that an oral test is probably more similar to actual radiology practice than a multiple choice test, right? Because when you open up a study from the emergency room, you aren't given choices A, B, C, and D, and you have to pick which one it is, right? So like it's going to be different, and the preparation process to like take a case and to talk through a case in real time um, probably will translate better to kind of handling that surprise consult from the clinician who just drops by your reading room. It's like, hey, we just take a look at this case, and it's going to be something horrendous whenever they do that. And so it may, it's something that we need to be able to do as radiologists. We need to be able to take a case and talk through it and explain what we're thinking. That being said, there are certainly some negatives to this, and many people, myself included, are probably more likely to have mental lapses in kind of an oral exam setting. Someone asks you a question and you immediately forget everything, including what your name is. And like that's just how I am, and a lot of radiologists are probably that way as well. And whereas these people may not struggle as much with the multiple choice test, I expect that the material covered on an oral exam will be more basic on average than what would be typical for a multiple choice exam. But one interesting thing about this whole thing is that I've taken the certifying exam, and although I'm not sure that it's officially published, the pass rate is quite high for the certifying exam. And so I assume that will stay the same for this, but it certainly will be interesting to see how that plays out. And if you have a test that 100% of people pass, then what's the point of the test? Some people would argue. So I don't know. I'm curious to see about that. One other thing about that test is I think the current plan is for it to be taken during fellowship. Um, and whereas the certifying exam is taken after fellowship. At least that's the current way it works. So you take it usually about 3 months after you finish. If you're taking a 1-year fellowship, it'd be 3 months after that. And I'm curious to see how that impacts, that fellowship year. If you're having to still study for a test, does that impact your ability to learn what you were wanting to learn during fellowship, or is that going to be diluted by trying to keep up on all the other things, keep up on the things that you're not studying in fellowship? So I'm not exactly sure what to take on that. I think there are a lot of more experienced radiologists who will be excited to dust off their case files and get them back out for some hot seat sessions. But it's a lot easier for me and you guys not having to take it, to just think about how that might be. But yeah, I'm certainly curious to see what will happen, and I don't know, we'll see. I guess it's coming one way or another, right?
Yeah, I couldn't agree more. I think the best way to learn to consult is to do the consult, right? I
Right.
think, I just think of myself when I was in the beginning of my R1 year and I was getting a phone call and I was super nervous. Now, after having gone through this in a call setting, I'm definitely more confident. If I don't know anything, I can pull it up. I just have resources at my fingertips, which a exam won't be able to simulate. However, I do understand, from like a preparation perspective, that preparation is getting us closer to the actual format of the job, then it has its benefits. But then again, a test, people study for a test and only prepare for the test to pass the
Right.
test, right? The ancillary benefit of having the real life sort of experience or simulated real life experience, oftentimes I don't see it as great to the point that justifies keeping the test, right? For the inconveniences of the test, right? And so, like, I think all residencies and fellowships in some extent do incorporate, tour boards or multiple, it's always the fellows who are taking more call, hence they're picking up the phone more often, are being on consults more often. So I think it naturally leads to a ton of experience that we need as attending. So, do we really need that oral board to come back? I don't know. But we've produced great radiologists before the oral board existed. We've
Right.
produced great radiologists when the oral board wasn't there. And we'll continue to produce great radiologists after whatever format the test takes on, right? So, I'm pretty neutral / negative. I'm just thankful that I don't have to go through the experience. We've been doing multiple choice exams since the MCAT, and so it's a familiar format to us. So,
Right. Since first grade, right?
Exactly.
All the way
yeah,
through all
since
of
first
training,
grade.
you've done multiple choice tests. Yeah, maybe someday you'll be the head of the ABR and you can decide what the correct path is. I
I
don't
can't
know.
imagine all the hate mail that
I know, right?
And lastly, I think here's a question that I'd like to get your opinion on. Now there's a kind of a cultural push to either produce fellowship trained radiologists or push for fellowships to become longer and longer. In neuroradiology, for example, at many academic institutions or even bigger private, more specialist private practices are pushing to get 2-year neuro fellowship trained neuroradiologists, right? And to practice even anything else other than, I guess, emergency radiology, there's a push to get quote unquote fellowship trained radiologists to read their stuff. What do you think about that change, right? I think, have our residencies become a point where, we're there to learn what fellowships we're going into, then we can start doing quote unquote some real work? Or, are the changes we're seeing in our online radiology curriculum, right, whether it's CaseStacks or many different online platforms, does that obviate the need to have kind of these prolonged fellowships or being quote unquote a fellowship trained radiologist? Along the same vein, I want to ask, what are your opinions on intern there? Right.
Yeah, those are great questions. So my dad is a radiologist. He been private practice radiologist for years, and he did his residency training at University of Virginia in Charlottesville, and he did 4 years. So he came out of medical school. He didn't do an intern year. He did 4 years of residency and then went straight into, private practice world, which in the 90s was pretty good time to be radio, it was pretty good. And me on the other hand, I went through training, did an intern year, did 4 years of radiology residency, and I did do a 2-year neuroradiology fellowship. So I did 7 years, which is, in case you're counting, 3 years longer than what he did. That's a lot of years, actually. And so yeah, so what is the point of all of that? Intern, I'll start with intern year, and then I'll get to the other part of your question. Intern year is I go back and forth on. I think I did get some benefits from it, just being able to, relate to the referring clinicians, having been someone who ordered studies. I think there were certainly some benefits in that. So I don't think it was a completely useless endeavor. While I was going through it, I'm sure I would have been happy to just skip the experience and move on to residency. But it certainly is interesting. There's other specialties like pathology that don't require or that don't have an internship experience. So I don't know. I think that there is some value, but is it worth the year of torture that that goes into it? I'm not entirely sure. So I wish I had a straightforward answer on that one. As far as fellowships goes, it's kind of interesting. There certainly is at least among some people a cultural push for longer training, and just to take the case example of neuroradiology, which historically has been a specialty that is pushed for 2 years of fellowship training like I did. I think that that cultural push is likely to be completely drowned out by the desperate need for radiologists. And the job market right now is crazy. You go to any institution, certainly any academic radiology group, and ask them if they're currently hiring, and they will try to hire you on the spot, probably without asking your credentials. There's a huge demand for radiologists right now, and I think that that is going to drown out anyone's ideas about how long training needs to be. And so I think that the job market is pushing for shorter training. And so our institution actually, I was the last 2-year fellow. And so since my time, everyone has only been doing 1 year neuro fellowships. And we were an institution that historically only really hired people out of training that had done 2 years of radiology fellowship. But since that time, we've been hiring people with just 1 year of experience, 1 year of fellowship training. And so getting back to the online component of this, yes, I think that online platforms, like I would advocate for CaseStacks, MRI Online is a great program. There's lots of good resources out there. May kind of help supercharge that fellowship training experience. And maybe you can get more out of that year than you used to be able to. And I think that programs have moved more and more to making sure that that is a very educational year and not so much a scut work year, And so I think that fellows, with that year of training, at least what I've seen at our institution, they probably don't need a second year of training after completing what they've done. So I think I don't know that we'll move to the point where fellowships aren't needed anymore. Because I think that they're certainly it is very attractive to our ordering clinicians to have reads from fellowship trained radiologists, and there is a difference in how a fellowship trained radiologist interprets studies compared to a generalist. But I think that online resources can really help make that fellowship year more powerful and help make sure even after 1 year of fellowship training that people are pretty ready to hit the ground running with their careers.
Well, I want to be mindful of everyone's time. So, Kevin, thank you so much for coming on the podcast. This was excellent to hear your journey, the current state of CaseStacks and where you're developing it in the future. Very excited to kind of see your team's progress.
Thank you. Thank you so much for having me. This has been really fun.
Awesome. Great. Thank you.
Yeah, no, thanks so much for coming on, Kevin.